I'd just like to say a big thank you to Ellie and to the Lindsay Leg Club Foundation for inviting me here to speak. I think it's very pertinent to speak about quality of life and the impact on wound management. I absolutely loved Wendy's presentation, and I think it follows on nicely from that. We're all here to ensure that our patients have the best quality of life. That's why we go out to work every morning. That's what we're here for, learning here today. So it's a great privilege to be one of the final presenters today, so thank you. The definition itself, quality of life, is quite hard to define, and I use the World Health Organization definition here. It's been around a long time, and people have tried to adapt and change it, but ultimately it's complex because we are complex individuals, and patients that we deal with and the lives that we live are complicated. And to sum it up, it's very much for me about how the patient feels at a point in time and what's going on around them. So as nurses, given the changing environment that we're working in at the minute, it's very hard, I think, to juggle, the patient, the family, the relationships. But for me, it's very much about getting back to basics. I think we need to get back to the focus of the patient and the one-to-one care that we're good at, that we're here to do. As I said to Ellie last night, it's very much, we're here to serve, to do no harm. And I think, as Wendy said, it's about getting back to that ethos of caring, that therapeutic aspect of nursing. So for me, it's very much about the patient and putting them at the centre of their wound care. The early studies around quality of life, I think, were pioneered in the UK, and some of the great people like Christine Moffat, Hildegard Charles, and many, many more people who I haven't referenced here, their life's work has been around quality of life in wound care, particularly leg ulcer management. And some of them have gone on to publish this, and some of them are very much still in practice. And we owe all the new research to them. So they've done all the groundwork for us. And since then, there's really much been an explosion with research, internationally, in terms of all different types of wounds that we now deal with. So surgical wounds, fungating wounds, even skin conditions. And it's great to see that our international partners like Australia, Italy, Germany, they're producing some great work around quality of life in all the different types of wounds. So we know that wound care, particularly chronic wounds, cause pain, isolation, depression, loneliness, etc. Alongside this, we have the burden of chronic wound care study, which many of us, we've all spoken about it today. There's an increased cost of care. Most of it is our nursing time. Leg ulcers are the main burden of chronic wounds, and most of these wounds are undiagnosed. So on one side, we know that the evidence says that chronic wound care is a huge cost to our patients and their quality of life. Yet, there's increasing number of these wounds, and a lot of them are undiagnosed. So how do we manage this? And I think we have to just really much have a focus, as Wendy said, about the individual. Every matter, every patient counts, going back to the basics of the care and taking each individual contact that we have. So following on from this, I want to present you with my research, which was very much around a marginalised, vulnerable group of patients that live with leg ulceration. And I work with them quite closely in the Royal Free and have done for the last 12 years. And they're patients who have a history of injecting drug use that live with leg ulceration. And I'm going to present with you now, as they would have wanted for me to share their narrative, their perspective, their story, their voice of how they've lived with their leg ulcer. So this was the patient information leaflet, and when I first started to think about the design, how I was going to capture this marginalised, vulnerable, yet chaotic, nomadic group of people, how do I capture it in its purest form and portray, without intrusion from me as a nurse researcher. And I was really interested around the narrative perspective, the narrative paradigm of storytelling. And it's a very, very powerful, unique insight into people's lives, because ultimately they share us their story. So it removes us in some way as the researcher. So it was very important for me to be able to have a unique insight in that way, because obviously there was bias, me having access to these people from a nurse researcher perspective. And they were willing to share. They wanted to voice their journey, their experience, their story, and they felt it was missing. And it was. When I did the literature review, it was very much missing in its unique, purest form in the evidence that we have today, not just in the UK, but internationally as well. So I'm going to talk you through a little bit about the study design. So it was a qualitative study, and I knew it had to be quite robust in terms of delivering that, because getting access to these group of people can be difficult. And also there were questions around, would they complete the study? How would I get them on board? How would I recruit them, and how would I retain them? So I was absolutely determined to capture this in whatever way I had to. But I knew that the ethics, because I was using NHS patients, had to be rigorous. So I decided to use two different methodologies, diaries and interviews. So the diaries were collected over 4 weeks, and then they were collected, I transcribed them myself, and I did a brief thematic analysis of these diaries. They all completed the diaries. The interviews then followed up within a week or 2 weeks of actually a thematic analysis of the diaries, and again I transcribed each individual hour-long interview, and I did another analysis. So the participants themselves were fascinating. I'm going to talk you through a little bit about them. So altogether 10 were recruited. They may seem like a small sample number, but actually think about the narrative that we're collecting here. These are people's stories. So 10 diaries from people who are hard to actually get access to, who are marginalised and vulnerable, is quite a considerable amount, plus 2 data sets. The age numbers between these participants was quite interesting. So the youngest participant was 35 years. He was married, he had a child. The oldest was 61 and 62 years. They were actually married to each other, and they completed the diary data sets together. So it was very, very interesting for me to see the diversity and the variables there. Recruitment was in North London, and the data collection was over a year. So I recruited from three different recruitment sites, and the key people to these were my gatekeepers. So these were nurses working with these people, and they were the key ethical delivery for me to get access. So the analysis finally was thematic, so I looked for emerging and comparable themes, which I'll speak to you about, and I was able to analyze this using the software tool Envivo 11. This is an example of one of my diary packs. So each participant was given this, and they were asked to complete their handwritten diary in whatever way they felt. There was no right or wrong way. I wanted them to say how they felt at whatever time. They're also given markers to draw, which they did, which I'll share as well. And what I would like to say, there was no resistance. There was no difficulty in recruiting these people at all. They felt in some ways slightly marginalised from the general leg ulcer population, that they didn't quite fit in. And we know that's very much the case in practice. But what I will demonstrate is that their suffering, their isolation, is very much the same as the people that we care for leg ulcers. In fact, it's probably exacerbated even more so by their history of addiction. So we speak about narrative inquiry and narrative medicine being very powerful. I'm a firm believer that in order to treat a person, we must get to know them first. I am a hospital nurse, but I also go out to outreach clinics, and I know that when I go to the wards and I speak to doctors and nurses on the wards dealing with complicated situations, you know, we talk about bed numbers now, we talk about bed 21, bed 22, patient that we can't remember their name. We've kind of lost the focus about, you know, what patient care is. We need to know our patients. And for that, narrative is really powerful. Now, I know you're all sitting there thinking, how can we capture that when I have 24 people to see? Or my example is 40 leg ulcer patients on a Monday. Well, it's making that 5-10 minutes count, and just asking, letting them talk and listening to them is absolutely invaluable. And I'm very much a believer as well about handing this over to our medical surgical teams. And there's an example there of two of my patients who have a history of injecting drug use, or the term that's used now, people who inject drugs. The term intravenous drug user, or IVDU, which is plastered all over the medical notes, even if you inject it in the 70s once or twice, it follows you right through your history, which I think is quite unfair, because a lot of these people have stopped injecting a long time ago, but then they're predisposed to these venous ulcerations throughout their life. And they're very aware of the fact that of their history, and they blame that for their development of their ulcer. I'm going to talk you through now my findings, and I wanted to very much present the person, the mother, the father, the grandparents behind who these people were. So these are pseudonyms, but in the first instance of the findings, I produced a biography of these people. And I asked them, when they were completing their diaries, to tell me a little bit about the start of their life. And all of them connected the beginning of their life with their ulcer with their drug use. They all spoke about when they first started injecting. Now, within these participants, we have a teacher, we have a computer technologist, we have 2 grandparents, we have a postie, we have great diversity in terms of our patient demographics, which reflects the great city of London that we are. So we had a South African gentleman, ex-military, we had a chef, we had a Brazilian lady from a multi-millionaire family. Fascinating, interesting. So things are not always as they seem. People are not always as they seem. And if I hadn't given these people the time to demonstrate that, then I would know no better about them. So I think it's about challenging our prejudgments, and it's very much about reflecting on ourselves as nurses. So the themes that came through these qualitative data sets, well, there were many. They wanted to talk, and they were good at it. And they wanted to share their story of suffering, grief, but also pain. Now, any of you that have worked with people who have a history of injecting drug use or substance misuse in general, pain is a main theme, it's a main feature. Nobody knows how to treat the pain, nobody knows what to do. Now, my data did not demonstrate a clear answer to that, but what it did show is that people who are in pain from their leg ulcer, who have a history of injecting drug use, if they have a good experience from us, if they have a good contact, that in itself demonstrates healing. They will then come to your clinic. They will then come and see you. They ultimately trust you. So pain was not just a physical stimulus. They very much had suffered throughout their lives with, as I say, the detriment of their drug use to their families. Shame, grief, and punishment. Again, I will demonstrate this. But there was also positivity. They had great humor, and they used the humor throughout their data sets. But I also, reflecting on it, think they used humor to protect me as a nurse researcher. So they were very much, I think, trying to, as I say, protect the people around them. There was caution in the data sets. So those people who had completed them, who came out the other end, realized actually what had happened to their lives from injecting. And they were very much, I quote, if you inject heroin, there's only one place you're going, the box, the nick, or the gutter. But again, that was said with humor. I think we can learn a lot from people who I call very resilient and very selfless, and that in itself challenges the current medical literature that is out there around these people, which calls them chaotic, uncompliant. It's not the case, and I think that's the real insight from my thesis. My surgical team, who knew my vascular team, which those of you who work with vascular teams will know that injecting drug users are the bane of their lives. And I've done a lot of work with my team over the years that I've been completing my doctorate, which was 6 in total, about challenging their stigma around these people. And one of the first encounters I had with a registrar was, Jemell, can you go and see that lady in bed 22? She's an IBDU. I said, certainly. Does she have a name? You know, this is the type of acronyms we need to, he smiled at me. I don't think he meant any harm by it, but that in itself is labeling. We need to challenge that. We need to re-educate it. So when I was telling my team I'm going to present today, they said, you have to include a slide on this guy called René Lariche. Now, Lariche was a pioneering vascular surgeon. He was a philosopher. He was way ahead of his time. And basically, he published 2 books, pioneering books after the First World War, because he was involved in looking after people during that. One of them was about the philosophy of surgery, and one of them was about pain and the complexity of managing pain. Of course, he had been involved with people after the war, so he realized that pain was just not a physical stimuli. So fascinating. The other book, The Philosophy of Surgery, which I'll tell you, he said in the 1940s that in the future, that vascular surgeons would go and operate on a patient that they never even met. And in those days, that was absolutely unheard of, that you would not know your patient. Unheard of. But we know that's not the case now. We're meeting people, we're expected to provide wound care for them or operate in them on that day without even knowing, without even asking, with a 10-minute slot in your GP practice. So these are examples and drawings from the participants that completed the data sets. This is from the lady who was married. They were married 35 years. She was a teacher, and she continued her teaching training. She was actually taking heroin at that point. She's actually on one of our patient involvement groups for the CCG in our local area, and she's very actively involved. She's a great grandmother, and she minds her grandkids for her daughter. She was keen to portray how she felt living with her leg ulcers, and she says, "They look like shark bites on my legs. I can't wear trousers or skirts, excuse me." She talked about the fizzing and the burning. The other thing that was mentioned was around pain and how methadone, those of you who work with people with substance misuse, or I suppose general practice, we have this myth that methadone is a painkiller. It is not a painkiller. I would really much like to say that today and for everyone to take that away. It is not. It's to help people who are withdrawing from a substance to help relieve the withdrawal symptoms. It is not a painkiller, and people who have pain need to actually be assessed in full. And they were very clear about that. They said, if there's anything we want to come out of this research, we want you to tell clinicians that when I'm on the ward kicking off, it's not because I want more of this or that. I need my methadone, which is not a painkiller. This is another example of a lady who drew her ulcer for me. And I think it's probably best up on that screen. But it tells me the detail, the talent, and actually how she felt about living with this wound. She took the time, she's quite a young woman, to draw the intricacy of her wound. And she was self-caring a lot. And again, I think that's a key part of this study, to actually, take the self-care that these people are willing to. They want to, because they can't always walk to get to the nearest clinic. They want to be able to self-care, and we need to educate as well. This is an extract, again, from the diaries, and they talk about stigma. And they talk about the ulcers being painful and smelling. But sometimes you feel like you deserve the suffering. You want to punish yourself for being weak, a liar, and a junkie. And there's also terms like leprosy. The very good news is that also with healing, which featured strongly in the data set, and concordance, is that when these patients were in contact with reliable, consistent care from kind practitioners, these wounds healed. And they came to the appointments. And that is quite something. And it challenges everything that we know around these people. Again, there was poetry within the data sets, and one of the ladies who had her ulcer while she was in jail, she talks about, in this poem, how jail saved her from crack, and she names it Mr. Crack. And again, it's the ability to be able to reflect like that after so much suffering and pain in your life. I find it quite incredible, and they inspire me for that, the ability to reflect as such. I'll leave it for a second so you can read it. The diaries themselves were very cathartic and therapeutic, and I would encourage all of us who are in practice, who maybe don't have the 40 minutes with our patients, encourage them to complete diaries. Give them the opportunity. Reflection is really powerful, and it helps us build our coping mechanisms and our resilience. And that's not just for patients, that's for us as well. So I think there was lots of insight to gain from this. There was also great positivity. So they drew, they colored, they carried these diaries around with them for 4 weeks, which I thought was quite incredible. But they wanted to show both sides. They wanted to show the person, the mother, the grandmother, but also the person living with this chronic ulcer. dealing with maybe encounters that were not always so positive, but they still believed. They were very aware of the pressures of the NHS. They were very grateful for the care that they received. They knew that they sometimes were not always on their best behaviour. But what I would say of some of the clinical implications is that you need to be extremely patient. You need to be understanding. It teaches you a lot about yourself as a nurse. And I think there people who suffer like this can teach us a lot. I've certainly learned a lot from them. And this heal spidergram is actually taken from the Collins Dictionary, the definition of healing. And I think it's very much takes us back to what it means. You know, it's not just to cure the ulcer, but it's very much about the well-being of the person, the safety, the recovery, and the physical and the emotional. So it's multifaceted. And we have a key part in that in nursing. We really can make a difference. So there are common themes between the general population with leg ulceration and those with a history of injecting drug use. And I would also add that some of those are exacerbated in this population. By appreciating the person behind the story, we can establish common ground. And if you can find that common ground with people who society consider challenging and difficult, who I would say are not at all, if you have time to listen and care, you can really make a difference, really make a difference. It improves concordance, and my data proves that. It improves patient experience, and it improves quality of life. And current policy and agenda should be inclusive of all people who live with a chronic wound. And there's some references. Thank you.